We now move to another important debate. Tim Lawton to move.
Thank you, Mr Bain, and I beg to move that this House has now considered the reduction in the number of health visitors in England, and I'm very grateful for a number of members who've come to speak in this important subject. I declare my interest as the chair of the All-Party Parliamentary Group for 1001 Critical Days from Conception to Age 2, and I also chair the Board of Trustees of the charity, the Parent Infant Foundation, which runs attachment facilities and lobbies for better early intervention around the country. Can I start, Mr Bone, with some slightly alarming statistics? That the cost of perinatal mental health in this country has been worked out at £8.1 billion per annum, according to the Maternal Mental Health Alliance, with up to 20% of women experiencing some form of mental health problems during pregnancy or the first 12 months after birth. That the cost of child neglect in this country has been estimated at some £15 billion, and 50% of all maltreatment-related deaths and serious injuries occur to children under the age of 1, or I should say infants and babies under the age of 1. So we're currently spending in excess of £23 billion getting it wrong in those early years, particularly for mums and new babies. That's equivalent to something like half of the defence budget. There are 122,000 babies under the age of 1 living with a parent who has some form of a mental health problem. Amazingly, and this statistic came out time and time again during the Domestic Abuse Bill, a third of domestic violence begins during pregnancy, and suicide is one of the leading causes of death for women during a pregnancy or in the year after giving birth. About 40% of children in the United Kingdom have an insecure attachment to a parent or carer at the age of 12 months, according to Professor Peter Fonagy and others. And alarmingly, there is a 99% correlation between a teenager who may be experiencing some form of mental illness, depression at the age of 15 or 16, and the likelihood that his or her mother had some form of perinatal mental health and had some form of illness during pregnancy. It is that close a correlation, making it that much more important that we make sure mums and fathers, but particularly mums bearing those children, are as happy, settled and healthy as possible in those early stages, from conception to age 2. I'll give way.
I thank the honourable gentleman for very, very kindly giving way. And he set out the costs that are incurred by trying to prevent such travesties as he sets out. Does he agree with me that actually the figures he refers to are conservative estimates? And in fact, I believe he was at the launch of the Maternal Mental Health Alliance that he refers to, which was quite a number of years ago, that arrived at the figure over £8 billion. And isn't the case that the economic costs are significant, but it's also the social and moral reasons which brings members on all sides of the House here for this very important debate today?
Well, if she's patient, I will come on to the social impacts. And these figures relate to, I think the MMH report came back in 2014-2015, and so obviously things have moved on, although, of course, the birth rate has slightly fallen in that time as well. But these are very substantial figures financially, but, as she says, most importantly, socially and the impact on the child. And if we look at some of the physical impacts as well, child obesity rates in England are amongst the worst in Europe, whilst breastfeeding rates in the United Kingdom are one of the lowest in the world. We have rising emergency department attendances by children under the age of 5, and infant mortality reductions recently have stalled. And of course, I think just last week we had the worrying figures about the dwindling vaccination rates in England, in particular, with only 86.4% of children having received a full dose of the MMR vaccine, and we've effectively lost our immunity status because the World Health Organization target is 95% to protect the population from a disease. And the Children's Commissioner estimates that in total 2.3 million children are living with risk because of a vulnerable family background, but within this group, more than a third are invisible, effectively, not known to services, and therefore not getting any report. So we're talking about an expensive and a widespread problem as well. I'll give way.
Thank you, Member, for giving way, and I would like to pay tribute to the remarkable work of health visitors in my own constituency, Eastbourne. But on the very issue that the member is talking about, would he agree with me that having cut to the health visitor service so that it's actually 30% down over the last few years is clearly making it even harder for the profession and also for the families and the mums that they take care of.
Well, again, I ask the honourable gentleman to be patient because I'm going to come up with all that, but I realise he wants to put on record his tribute to the health visitors in Eastbourne, as would I, as somebody who was born in Eastbourne and had wonderful health visitors, I'm sure, albeit 57 years ago now. Now, the one thing that all these problems have in common, and a lot more I haven't mentioned, is that they come under the remit of the health visitor to some extent or other. The health visiting service provides an important safety net for infants and young children, as well as mums and dads, who are at particularly high risk of having their needs missed, as they're not visible in the same way as children who are accessing an early years setting or a school, for example. Another one, yes, why not?
He's making a very good speech, and
but you keep interrupting it.
and I'm very pleased to interrupt him just briefly. I mean, I too pay tribute to the health visitors in my own constituency. But isn't an important role that they play is in ensuring that health inequalities are drummed out of the system?
The very serious point, my honourable friend is absolutely right, that health inequalities, which are still a big problem in this country, it is those professionals on the ground, not least health visitors, who are the first to come face to face with it and have the practical means, in many cases, to do something about it as well. I'm very happy to take interventions, but it means there will be shorter speeches, as I'm sure you would point out, Mr. Bain. I'll give way to the Honourable Lady.
Very briefly, I thank you for giving way. I've got the Royal College of Nursing briefing here, and in this briefing it says that I'm going to talk about the increasing caseloads. The number of health visitors that have got caseloads of over 500 children have risen from, it says in here, from 12 to 21%, and that was only between 2015 and 17. So it's going to have risen even more in the 2 years that have elapsed since then. So the caseload as well is really worrying when you think of people getting missed. Sorry.
Well, I think she's preempted a point I was going to make on page 5, so I'll take that bit out in a minute. Now, unlike some other public service professionals, health visitors are non-stigmatising. They are usually welcomed over the threshold into homes, enabling them to give early advice and support to prevent later problems, encourage healthier choices, detect problems early, also in some cases to act as an early warning, safeguarding alarm too, which often when which I will finish my sentence, which often when social workers are ones to knock on the door, it may be too late and it's a completely different sort of relationship that professional will then have with the family. I'll give way.
Tremendously grateful to him for giving way and actually for securing this debate, which I think is extremely timely. What he's just said, I think, is so important because the mandatory health visitor contacts in my constituency are not taking place as they should. And when constituents complain or I complain, they're essentially told they're profiled based on the risk. That is not how a mandatory set of contacts should clearly work. And I worry that we make sometimes assumptions about perhaps socioeconomic status or other factors when actually the kind of problems we're talking about here can manifest themselves in any family. And if we're serious about having a mandatory system, shouldn't it be that, not discretionary? And if that's about capacity, let's talk about that.
Well, again, the Honourable Gentleman makes a very good point, which I have on page 5. And this is an issue that affects everybody across society. And often it's better off more affluent areas who might be better at hiding it or less inclined to come forward to seek help. And I have to say that in the charity that I chair, where we have units in Liverpool, in Newcastle, in London and so on, we are seeing middle-class parents coming forward who've got serious attachment dysfunction problems with their children and are less likely to come forward. And those, ironically, may be harder to reach people as well. Health visitors are the early warning system to be able to signpost some of those people to get the services and also to point out, I think you've got a problem as well, and they'll take it on trust. If I can make a bit of progress now, and I appreciate some very good points that have been made, because the cost of failing to intervene early is enormous, financially, as I've already said, but more importantly, socially, as the impact of not intervening early can disadvantage a child through early years, school years, adolescence, often into adulthood, and also becoming life-defining in some cases. So that's why one of the great achievements of the coalition government was the pledge of a massive increase in health visitors. And in opposition, the then Shadow Health Secretary, Andrew Lansley, championed the recruitment of no fewer than 4,300 new health visitors based on the successful model of the Dutch Kramzorg system, which I was part of the research into, where postnatal care is provided to a new mother and her baby in the initial 8 to 10 days immediately after birth in particular. Now, 4 years ago, the government's health visiting implementation plan and the call to action scheme were the pride of the nation, frankly. This policy was built on sound evidence that the health visiting profession had the power to drive health improvements and provide a universal service designed to give every child that best possible start in life as we all want to see it. And impressively, for a government target, it was achieved just about in the lifetime of that 2010-2015 Parliament. But depressingly, since then, the numbers have started to drop dramatically. In June 2015, there were 10,042 full-time equivalent health visitors in England, but a year later that had fallen to 9,491, and the latest figures show not 30%, 31% drop from the peak. And according to the Institute of Health Visiting, 1 in 4 health visitors do not have enough time to provide postnatal mental health assessments to families at 6 to 8 weeks, as recommended by the government. And in addition, 3/4 of respondents to a survey that the Institute put out said they are unable to carry out government-recommended maternal health checks at 3 to 4 months after birth. And that, of course, is a crucial stage, Mr. Bone, to pick up mental health problems with the parents, which may already be impacting or probably will impact on the infant. It's not just about looking after the babies, it's about looking after the family unit and the primary carer in particular. And to a large extent, the reason for this has been the transfer of responsibility for health visitors from the health service to local government as part of their enhanced public health responsibilities. Now, I'm not challenging the wisdom of doing that, but it has come at the same time as the greatest squeeze on local government spending recently, and the architecture of the delivery of health and wellbeing services for babies and young children, I think, has been disorientingly fragmented between local councils, CCGs and NHS England, with insufficiently qualified scrutiny of how it works or not. And I do think there is an issue around the quality of informed local authority oversight over many of these public health roles. Now, councils have seen... Yeah, of course.
On this debate, he's been so consistently right in this area. My research ahead of today's debate presented a pretty worrying picture, I'd say, most of all from GPs in Winchester who report a distant relationship with health visitors, not their fault, but because they're so thinly spread. So would my honourable friend agree that as well as more of them, we would be smart to address where they sit in the system and maybe to co-locate teams around the emerging primary care networks would be the smart place for them to live?
I, first of all, pay tribute to the real acknowledgement of the importance of this area by my honourable friend when he was Public Health Minister, and always prepared to take our sometimes quite annoying approaches on trying to prioritise this. And he may well be right. I'm not too concerned with process and structures. I'm concerned with getting the professional face-to-face with the particular parent and baby. And we need to be smarter where we can actually make that engagement happen and make sure it's not through lack of the workforce in order to do it. If he wants to come back very quickly, it's going to eat into his own speech time.
I think the reason why that's important is because the primary care networks and the GPs who rightly run them are responsible for the outcomes of those patients that they manage within those lists. And if they have ownership of those health visitors because they're commissioned within that structure, I think then they have every incentive to close that distant relationship that I mentioned.
He may well be right. It's interesting that one of my own constituents is a health visitor. The phrase she quoted to me was that the current status of health visiting is not serving families well, based as it is on universally delivered process outcomes, which risk ticking the box but missing the point. And I think that plays to the point he's making. The most successful ways of dealing with vulnerable families is if we use children's centres, for example, and I'm not going to go into the whole argument around children's centres, the most successful ones I've seen are those where literally there is hot desking going on between a district nurse, a health visitor, a social worker, a school nurse and others, who are signposting. Some of the health visitor may get over the threshold and say, look, I'm a bit worried, there's a mental health problem there. When I go back and see the community mental health nurse back at the children's centre, I might suggest that she has a word, or whatever. That's the way it must happen, because these are all interlinking problems, and it's not just down to one professional to be able to treat it. But on the local authority, public health budgets have seen a significant reduction from 2015. The recent 1% increase for 2021 is welcome, but there's a lot of distance to go to reverse some of the past reductions, and some areas have suffered disproportionately. I'd flag up Suffolk, where I gather the Council have been considering plans to slash the health visiting workforce by 25% to save £1 million. I think it's a real false economy and short-sighted. So the decline in the number of health visitors since 2015 has been due to qualified nurses retiring or moving to other roles within the health service and too few trainees entering the profession. So alongside workforce cuts by local authority commissioners, the health visiting profession is facing also recruitment and retention problems and falling staff morale and poor progression opportunities. Health visitors have also raised safeguarding concerns as their caseloads increase to meet increasing need and cover shortages. And in their 2017 survey, the Institute of Health Visiting, health visitors reported that children are put at risk due to cuts in the workforce and growing caseloads, finding that 21% of health visitors are working with caseloads of over 500 children. I think that's a point that was made by one of the honourable members over there. Why not? I've given way to everybody else.
Thank you. I'm most grateful to him. When health visitors visited me in my constituency surgery in Penkridge, their frustration was that they loved their job, they wanted to do it properly, and yet they couldn't do it to the best of their professional satisfaction because of the caseloads, because there were too few of them, and they wanted to serve my constituents, the mothers, the families, the children, but they could not do this because of that. It showed I had huge respect for their professional attitude, but their real sorrow that they couldn't do the job as well as they might have wanted to.
My honourable friend is absolutely right. I've met many health visitors. They are a fantastic resource, do huge amounts of good, work well beyond their remit, and are frustrated by some of the processes and financial considerations that are stopping them doing their job to the best of their ability with sufficient support. Right, that's the very last intervention I'm going to take, and I want to finish shortly.
And one of the greatest frustrations is when families don't let health visitors in, which is a growing trend, where they find they come back time after time and there is either nobody there, or more particularly, the people are there, but they won't let them in. And this is a very worrying development.
Well, that is a point. The point I made earlier is that if one contrasts with social workers, where there's become a safeguarding issue, it's a completely different dynamic and relationship between somebody. And there's a reluctance to let them over the threshold. It's less of a case with health visitors because they are seen to be there to help. But there absolutely is a reluctance from some people, perhaps out of ignorance as to what the health visitor actually is there to do, from people who think, oh, I know it all, I don't need you, or for some people who may fear they have a vulnerability, could end up in their child being taken into care as well, which is why it's so important that friendly face on your side to help you being a new parent is the role that the health visitor does that certain other professionals just can't do. Now, according to the Institute of Health Visiting, the State of Health Visiting survey a few years ago, 1 in 4 health visitors do not have enough time to provide the postnatal mental health assessments to families at the 6 to 8 weeks as recommended by the government. Again, the Honourable Gentleman was mentioning that because these PMH checks are a key part of the government's maternal mental health pathway, and previous research involving clinical trials with 4,000 mothers found that those who received health visitor support were 40% less likely to develop postnatal depression after 6 months. And there are 5 mandated reviews under the Healthy Child programme, Mr Bone, that health visitors undertake. And whilst these are spread across the first 1,001 days, they are concentrated in the first 12 months, and health visitors would say that they're concerned that the number of reviews is actually insufficient and leaves too large a gap between contacts with families. So not enough of these scheduled ones are happening, and actually we probably need more intensively at those early stages. So to finish, there was also a lot of concern about steps being taken to help recruitment. And I tabled a question which the Minister kindly answered just earlier this week, where I asked her what steps the Department is taking to reverse the fall in the number of health visitors. And she answered that since 2015, local authorities have been responsible for the commissioning of services for 0 to 5-year-olds, and as such, they determine the required numbers of health visitors based upon local needs, which we understand. And a specialist community and public health nurse apprenticeship level 7 is currently in development. This will provide an alternative route directly into the health visiting profession. I'm afraid that answer raised some alarm with people from the Institute of Health Visiting, and the response I got back to that was to point out that the apprenticeship route is not an alternative route directly into health visiting, Applicants still need to be nurses or midwives, and the course presents a number of risks. It is longer. The endpoint assessment delays qualification unnecessary. It does not deliver a national strategy for the profession. Health visitors who are not employed by the NHS do not have the same opportunities to those covered by the NHS People Plan, and this includes NHS funding for continuous professional development, leadership development, pay rises, safer staffing and national action to address recruitment and retention difficulties. And also that local authorities determine the level of health visitors dependent on local need. But there is no measure of quality of service or guidance on how far the service can flex to meet those needs. And the apprenticeship is still not ready to be rolled out. It takes longer than present training, and it's more costly and therefore less attractive to employers and or recruits. So, Mr. Bone, an urgent workforce plan is needed to tackle dwindling health visitor numbers. I've spoken to representatives from the LGA. They are very concerned about this as representatives of local government. They want to get their public health role right. The LGA has said that it's offered to work with the Department of Health and Social Care, the NHS and Health Education England to help deliver a plan that would see the right number of training places commissioned, and it would also develop new policies to ensure health visiting remained an attractive and valued profession. And I hope the Minister is receptive, and I'm sure she is, to that offer. So what needs to be done? I just think we need to, again, value the role of the health visiting profession. And I'm sure all of us in this room and beyond would want to do that. But we have not just to will the inclination, we have to will the means as well. And I would point to the publication by the Institute of Health Visiting in England, a Vision for the Future, which makes 18 recommendations. I think they are sensible, practical recommendations. They will involve some investment. Just to touch very quickly on a few of them, that they want to see an urgent and ring-fenced public health investment. They want a review of 0 to 5 public health funding, and to cover the cost of delivery of the Healthy Child programme in full, all local authorities in England will need that funding. That they, as we await the refreshed Healthy Child programme as an interim measure, the proposed metric should be a floor of 12,000 full-time equivalents to restore the workforce to the target figure calculated for the health visiting implementation plan of 2011-15. New national standards for health visiting are needed to support consistency within the profession, and the title health visitor and its role should be protected and restored to statute, and a review of health visiting training with a risk assessment of the impact of the removal of Health Education England funding of training and replacement by the use of the apprenticeship levy. Frankly, Mr Bone, I think those are sensible measures. I very much hope, and I'm sure the Minister will look at them positively, because frankly it is a false economy not to be doing this. And it needs to be part of a bigger shift in government policy, of any government. I think we're pushing at an open door towards an earlier, more intensive, preventative intervention approach from conception to age 2 especially, and health visitors are absolutely at the centre of that.
Yeah. Yes. The question is that this House has considered the reduction in the number of health visitors in England. It might be helpful to honourable and right honourable members to let them know that the wind-ups have to start at 5:15, and there are 4 members trying to catch my eyes. So if members could bear that in mind. Liz McInnes.
Mr Bone, and it's a pleasure to serve under your chairmanship. And I'm grateful to the Honourable Member for East Worthing and Shoreham for securing this very important and timely debate. Now, before I was elected to this place, I, as a lay rep, chaired Unite the Union's National Health Sector Committee. And because of this, I had a great deal of involvement in the work done by our health visitors and community practitioners under the umbrella of the CPHVA, the Community Practitioners and Health Visitors Association, which operates under the auspices of Unite the Union. I gave up this role in 2014 when I was elected to serve my constituents of Hayward and Middleton, but I do recall that at that time there was a great deal of disquiet and unrest about health visitor services as a result of the Health and Social Care Act being transferred from NHS commissioning to be commissioned by local authorities. And it would seem, certainly from what the honourable gentleman from East Worthing has said, and from readily available figures, that the worries at that time have actually come to pass, with the numbers of children's health visitors falling by 31% from 2015 to 2019. Now, the Local Government Association says that the levels of health visitors retiring and taking other NHS jobs, combined with too few trainees entering the profession, has led to the workforce being stretched to its limits at a time when the number of vulnerable children and families is rising. And with cuts to public health budgets, councils are struggling to afford the number of health visitors needed to cope with the workload. Figures from the Office of National Statistics show that the number of under-5s in the borough of Rochdale, where my constituency is situated, is just over 15,000, with just 52 health visitors in the borough, giving an average caseload of 290 children per health visitor, when the recommended maximum recommended by the CPHVA and the Institute of Health Visiting, the recommended maximum is 250. And with health visitors being so overworked, they may, through no fault of their own, fail to spot child abuse, domestic violence and postnatal depression, and have too little time to help mothers bond with their babies. A survey conducted by the Institute for Health Visiting showed health visitors themselves voicing fears of child tragedy as a result of increasing caseloads and high levels of stress. And with year-on-year cuts to our public health grant, it is difficult to see where the funding is going to come from to provide and improve this vital service. In the borough of Rochdale, the public health grant is now £3 million lower than it was in 2016-17, decreasing from £19.7 million then to £16.7 million in 2018-19. For this financial year, 2019-20, the budget has been cut yet again to £16.3 million, giving cumulative cuts over the past 4 years in the borough of Rochdale of over £8 million. Nationally, councils' public health budgets have reduced by £531 million between 2015-16 and 2019-20. Now, I welcome the fact that in the NHS long-term plan, the government pledges to look again at commissioning arrangements, not just for health visitors, but also for school nursing and sexual health, areas of health provision, which are also suffering with increasing caseloads and staff shortages. And it is my hope that responsibility for commissioning will revert to the NHS, and also that this will be adequately funded and resourced, and I will be very interested to hear the Minister's comments on this. And before I conclude, I just want to mention some good news about the CPHVA. The association has just appointed 2 high-profile vice presidents, Professor Gina Higginbottom, who was the first BAME nurse to hold a professorial role at a Russell Group university, and Sarah Rowbotham, who is a friend and a colleague of mine. Sarah worked for the Rochdale Crisis Intervention Team from 2004 to 2014, and helped expose the Rochdale grooming gang scandal. She is also currently the Deputy Leader of Rochdale Council. Their appointments are welcome at a time when health visiting and school nursing are facing this crisis of falling numbers. Professor Higginbottom has declared her commitment to reducing health inequalities in the role, while Sarah has pledged to fight for members' voices to be heard. And I hope that the Minister might find the time to meet with these 2 inspiring women. She will, I'm sure, find such a meeting productive and helpful in preparing a clear plan, a much-needed plan, to improve health visiting numbers and the quality of care provided for children and families.
Thank you. It's a pleasure to serve under your chairmanship this afternoon, and can I also congratulate the Right Honourable Member for East Worthing and Shoreham for securing this incredibly important debate and for the work that he does with the APG for the first 1,001 days. I want to start by paying tribute to the Institute of Health Visiting and, most importantly, to the army of health visitors themselves, because I know from my own experience as a mum to a 2.5-year-old and a 7-month-old what an important job they do. And I want to put on record in particular my thanks to Jill and Katie, who have helped me and my family. Because health visitors do a brilliant job against a backdrop of falling numbers, growing caseloads, and in some cases unconscionable pressures. Because I believe it's now clear in the wake of the cuts that we've seen to public health that we have seen that steady diminution of health visitors right across England. As we've heard, since October 2015, the number of health visitors in England has reduced by a quarter, from just over 10,000 to just under 8,000. And of course, this is going to pile on extra pressure to existing health visitors. As we've heard, nearly a third of health visitors have caseloads of over 500, which is twice the safe level which is set by the Institute of Health Visitors. And unfortunately, this can only have a detrimental impact on the quality of care, and I think runs the risks of being at best less helpful, and at worst being counterproductive to the very aims and goals of health visitors themselves. And there is mounting evidence, if we look at a number of indicators, that things are getting more challenging. Again, if we look at those figures for infant mortality, the reductions in that level have stalled. We've heard already, and it's something particularly close to my heart, the issue around breastfeeding. We now have some of the worst levels across Europe. And I say that as an MP in Liverpool, where so much work has gone on via our Bambi service to support mums in their homes to assist them in that effort. And we've seen a great increase in the proportion of women breastfeeding. Again, if we look at our country-wide level, they are still far lower than they should be. We are facing an obesity crisis. As we've heard, our immunisation rates are falling. We missed that target for measles, and we've lost that measles-free status as the UK. And we are living through a mental health crisis, and I say that reflecting on the fact that as a woman, the period in one's life where you're 30 to 40 times more likely to experience a period of psychosis is in the year after birth. This is exactly the moment in a woman's life where that extra additional support is needed. And we, in addition, see a particular challenge where these adverse outcomes are not evenly distributed. And this is where we come to the issue of health inequalities. It's an issue which falls very far down the agenda and gets much less attention than it deserves. But we're still seeing, in fact, we're seeing a widening of this issue of where poor health goes hand in hand with your postcode, your income, family social status, and what your parent or parents do for a living. And we see that impact of inequality keenly felt in too many areas, including in Liverpool and other disadvantaged neighbourhoods. We're seeing nearly 70% of health visitors report that they are having to access emergency food aid going to food banks on behalf of those families that they are seeking to support. And the Institute for Health Visiting states in its report that these inequalities result in poorer physical and mental development, poorer academic achievement, and poorer employment prospects at every stage of that child's life. We are here talking about the most fundamental of issues. How can we ensure that every child born in this country has the best life outcomes and the best life chances? And health visitors play such an important part in those outcomes. And they provide such vital intervention to support new parents. And the list of what they do goes on. And we've heard of them already. It also plays such an important part in terms of how we seek to prevent ill health in this country rather than to cure it later on. And health visitors play such a critical role beyond health, and whether that's supporting troubled families, whether that's improving early language development and learning at home, particularly where there might be a child with special educational needs, improving parental confidence and knowledge to avoid unnecessary trips to our health service. Health visitors should form part of a truly integrated system of health, care and well-being tailored to a parent and child with the right interventions, advice and support at the right time. And I reflect on this as a member of the Health and Social Care Select Committee, where we had a report that was out on the first 1,000 days of a child's life. And the first priority contained within that for every child is to receive all of those 5 mandated visits. And in fact, that those 5 mandated visits should increase, and we should add one to a visit at 3 or 3.5 years old to ensure that every child is ready for school. An issue that perhaps we don't like to talk about, but it has increasing levels of concern that we're seeing from teachers right across our country. I'm conscious that my time is coming to an end. I just want to reflect on that recommendation from the Health and Social Care Select Committee and to say that health visitors play such an important role. They support families where others don't have the opportunity to do so. They do enter into people's homes, and they are trusted. They are trusted. If I think about all the health professionals that I connected with as a new parent, it was my health visitor that I relied on. We need to ensure that we're not creating the conditions of a public health crisis for future generations, and I only hope that in the Minister's response we will get some glimmers of hope that we are going to see an increase in the number of health visitors, not a further decrease.
Under your chairmanship, and I'd like to congratulate the member for East Worthing and Shoreham for securing today's vital debate. The role of the health visitor is vitally important to our local communities. The health visiting service provides vital support young children and their families need to ensure every child has the best start in life. Health visitors address cross-government department priorities for children and give a voice to young children living with adversity who can in some cases be invisible to other services. And the health visiting service provides an important safety net for infants and young children who are at particularly high risk of having their needs missed as they're not visible in the same way as children who are accessing an early years setting or at school. Early intervention is vital for children and their families, and an effective health visitor service is a proven way to improve health outcomes and reduce inequalities. However, in January 2019, the Royal College of Paediatrics and Child Health raised serious concerns about widening child health inequalities, highlighting that universal early years services continue to bear the brunt of cuts to public health services. In Lincoln, my constituency, 28% of children live in poverty. Health visitors are desperately needed to make sure these children receive the support they deserve. And in 2015, the commissioning of health visitors was transferred from the NHS to local government. A bad move in my view. And this has resulted in a negative impact upon both the working conditions of local health visitors and the capacity of the service delivered to my constituents, as the funding's not ring-fenced. I'm deeply worried at the steps taken to divide the health visitors' role by Lincolnshire County Council, and I was very proud to support the health visitors' strike against the proposed changes. The changes will divide their role into two different job descriptions, which will create a flawed career progression scheme that restricts health visitors' career progression. All health visitors currently undertake the same training, and upon qualification, they are all expected to carry out every facet of their role on a daily basis. And it's my understanding that currently there's no rationale to explain why one health visitor would be demoted to a junior role description while another continues at the same level. And it's a fact that fully qualified top band sixes are leaving or have left in Lincolnshire, many with years of experience, due to a reduction in their status and an enforced 3-year pay freeze. We are losing an important skilled workforce that's invaluable to our community. And I have to say, as a qualified nurse, nurses and healthcare professionals don't go on strike without a really good reason. Analysis undertaken by Unite shows that those held back from progression due to these changes will lose a substantial sum annually in comparison to the NHS pay structure. I'm concerned that these reforms are not being undertaken in the best interests of the health visitor service, but rather as a mechanism to de-skill the service in order to reduce pay. Financial efficiency must come second to the well-being of our local communities. It risks the long-term social benefits created by investing in our children's future at a crucial early stage. And I'd like to ask the Minister today to make representations to Lincolnshire County Council, and please don't push it to one side and say it's a local government issue, in order to prevent the downgrading of the health visitor's role. This is really important in the Lincoln constituency, and I hope I'm being heard. It's important that Lincolnshire County Council recognise their professionalism and importance to our community and therefore reward our health visitors accordingly. Thank you.
Thank you, Mr. Bowden. It's a pleasure to serve under you in the chair, and I also thank the Honourable Member for East Worthing and Shoreham for introducing this really important debate this afternoon. The Labour government recognised the decline in the number of health visitors and therefore put in train the opportunity to have a health visitor implementation plan, which I was delighted as Head of Health at Unite, and I refer members to my register of interest, to see that plan come to fruition during my time there. And the ambition to raise the number of health visitors by 4,200 was a steep challenge, but it was a necessary one. And we've heard the reasons why, because health visitors are the real backbone of providing the early intervention of health services. They're the pioneers of public health and also are instrumental in addressing health inequality at a time when we know that there are real challenges around children's health. It's so important to know that there's a workforce there to deliver that. But unfortunately, as we've heard, the numbers have fallen from its peak at 12,292 by 31% today. And that is having a serious impact not only on young people and their opportunities, but also on the staff. We know from the work that the CPHVA has carried out that 85.3% of health visitors are experiencing stress. They have caseloads which are unsafe. And therefore, it's absolutely vital, and I ask this of the Minister, that she puts a statutory caseload figure on the books, because it's really important that we know that health visitors can work to a criteria where they can cover their caseloads. In York, we only have 29 health visitors to cover our city, a population of nearly 10,000 children, and that clearly isn't safe at all. Now, the Health Visitor Implementation Plan was a good plan, although very much rushed. So often we had mentoring being stretched from a one-to-one relationship, which is the norm, to often 1-to-6, is what I heard from some of those health visitors in training. And there wasn't any sustainability put into the plan after its implementation. And therefore, with an ageing workforce, we saw the rapid decline and people moving elsewhere in the health service, partly because they were placed in local authorities who, under the austerity measures, decided to not only cut back on the opportunities for train and to develop, but also on pay. Yeah. And that had a significant impact, and therefore downgrading was part of that. And we know for people who went to work in outsourced services, where obviously we can't get hold of the information through freedom of information requests about true numbers, we know that some of the conditions have been even worse, and people have left the service after their period of training, which is a massive loss to our service as a whole. Now, what we need to see coming forward, and I will rapidly move on to that, is a new health visitor implementation plan, which is properly resourced as well. We know from the report that the member for South Northamptonshire did around young people, that there was a promise in there. The comprehensive spending review would resource the future programme. But of course, we haven't had the comprehensive spending review, and therefore it's urgent that the government put money on the table to deliver this. We also need to ensure that we bring services back in health that have been outsourced, so there is proper monitoring over this service, that it's seen as a statutory service to be delivered. But I'm very interested in the ideas that have come forward in this debate, that it's moved either back into the NHS or by a proper partnership between health and local government, because the reality is that we need to see the right relationships being built for health visitors to deliver their programme. Finally, Mr. Bowen, because I appreciate time is tight today, is that we need to ensure that the right stakeholders are brought around the table. And it's brought to my attention that some consultation has taken place about how we should move forward on issues like the number of mandated contacts and so on, but not all the stakeholders are there. And I certainly would urge the Minister to meet with the CPHVA, who are the lead organisation representing health visitors, but also to ensure that as part of that cohort, we actually have people who are working in the profession who can really reflect what it is like on the front line today. Thank you.
Shadow Minister.
Thank you, Mr. Bowen. It's a pleasure to serve with you in the chair. I'd like to begin by thanking the honourable gentleman, the member for East Worthing and Shoreham, for bringing this very important subject before us today, and for the sterling work he does chairing the APPG on the first 1,001 days. We've had some really interesting speeches, and I want to thank all members who have spoken for some very convincing contributions that have outlined very clearly the massive contribution that health visitors make to communities and to individual families, covering all sorts of services, from basics like transition to parenthood, particularly helping new parents, support with breastfeeding and weaning, encouraging the full take-up of immunisations, where it's been pointed out we've had a very poor record, supporting the mental health of parents who might be feeling vulnerable in their new role, advice on a whole host of minor ailments that children might suffer, preparation for readiness for school, ensuring that developmental changes are happening at the appropriate stage, and that any special needs and problems are picked up early. The honourable gentleman talked about the issue for safeguarding and how important it was, and what the cost, not just the cost to the family, but the financial cost of services when that doesn't happen. Health visitors, as registered nurses with additional midwifery and community public expertise, to provide a tremendous role, and I don't think there's any disagreement in this room about the contribution that they make. Praise for them across health professionals is widespread. The President of the Royal College of Paediatrics and Children's and Health Visitors act as a frontline defence against multiple child health problems. The Children's Commissioner for England said, health visitors are an essential part of the country's support structure for young children and their parents. My daughter Anna became a new parent 6 months ago today, and ahead of the debate today, I asked her what she thought of her health visitor, and she said, we loved our health visitor. We didn't have consistent midwifery care, a different midwife every week before and after Nora was born. But we had one health visitor who visited me before Nora was born and told me she would be my health visitor throughout the early stages of becoming a mum. We found her especially helpful when Nora struggled feeding, when we'd been discharged by the midwife. We didn't want to bother the GP. She was just a phone call away and would pop in to see us. And I'm grateful to my honourable friend for Liverpool Wave Tree for the contribution that she outlined, the benefits she's had from her health visitors. So there's absolutely no disagreement on the value, though. And I would like to put on record my thanks to health visitors across the country for the sterling work that they do in considerably difficult and challenging times. And they are very much a British phenomenon. We are the envy of the world having having health visitors, and with good reason. We all know that there's nothing more important than giving children the best possible start in life. Bearing all this in mind, it is so distressing to hear that the number of health visitors is falling so drastically. We're going backwards, and it's extremely worrying. And I expect that the Minister might point to the fact that David Cameron increased the number of health visitors, but that is old news now, and the picture now is very different. In 2015, there were 10,300 health visitors, but by 2017, this number had fallen to 8,244. And the reality is that every month the numbers are falling. None of this is really surprising, considering that in late 2015, Public Health and the Commission of Health Visitors became the responsibility of local authorities. This transfer of responsibility was accompanied by a budget reduction of 6.2% and the requirement to cut year on year until 2020. Funding for health visitors is not ring-fenced, so is it any wonder that cash-strapped authorities are commissioning fewer and fewer? I raised my concerns about this last year with the former health minister, the member for Thurrock, and she said, and I quote, health visitors are probably the most important army in the war against health inequalities. They provide an intervention that is very family-based and not intimidating. There has been a decline which we really must address if we're to get the earliest, best interventions and best health outcomes for children. I totally agree with her. That was said last year, and the government has failed to act, and the numbers have continued to fall. The numbers of children have not fallen, though, and it's also very important to recognise the increased workload of the remaining health visitors. My honourable friend, the member for Haywood, my friend, the honourable member for York, and for Lincoln, all raised the falling numbers and pointed to the fact that the Institute of Health Visitors' current caseload identification is exceeding safe levels. The recommended maximum caseload for health visitors is 250. CQC report that the average is 500. And in the London Borough of Hounslow, the average number, not the highest, is 829 per health visitor. This is obviously impacting on their ability to deliver a quality service. And it's now true that the proportion of 6 to 8 week reviews completed for newborn children ranges from 90% in some areas and only 10% in others. It seems that vital workforce planning is a thing of the past, and our children and communities are paying the price. In the widest sense, this approach is so short-sighted. No health professional is better placed to support parents and children in those vital early years than health visitors. The early intervention of a well-qualified, accessible health professional can be the difference between children thriving or not. For every child that does not thrive, there is a cost, not just to the family, but to wider society. There is a wealth of evidence to demonstrate the high impact that health visitors have in key areas.
I'm sorry to interrupt the Shadow Minister, but there is a guideline of 5 minutes for Shadow Ministers in these debates, and it's 10 minutes for the Minister, and we're going to cut into a time. So I hope the Shadow Minister has finished the speech.
Can I just make a couple of final points?
Oh, of course. Very quick.
Thank you. Then, Minister, you've heard today the appreciation for the contribution of health visitors, and we're looking to you to address the future provision, to turn around this decline in numbers and outline for us how you're going to do that today.
Minister.
Thank you, Mr. Bourne.
Thank you very much indeed, and it's a pleasure to serve under your chairmanship. Firstly, I would like to congratulate the Honourable Member for East Worthing and Shoreham on bringing forward this very important debate and the degree of consensus as to how important health visitors are to each and every family that they touch. The contributions I may not be able to answer directly, but I will ensure after this debate that I've written to those that there is further points to make in due course. I would like to pay tribute to his leadership and support for children and young people, particularly the efforts to focus on those first 1,001 days, which can impact on social, economic and physical outcomes throughout life. I strongly agree with the importance of early years intervention and how strengthening support at the very start can stop those problems escalating and help the broader family, as both he and the Honourable Member for Liverpool Wavertree pointed out. You can stop it before it starts, or certainly intervene. He made strong arguments around the value of health visitors and their ability to cross every threshold, which I don't think can be underestimated. Good health is one of our country's greatest assets, and we can't take it for granted. Just as we save for retirement, we should be investing in our health throughout life, from the cradle to the grave. Starting in childhood, actually before a child is even born, we can help ensure our children enter the world and are raised healthy and happy. Most babies do get a fantastic start in life. They benefit from the support of loving parents and dedicated health professionals. But we know that some lives can be easier than others. Often it's because of circumstances over which they have no control and the conditions in which they're brought up. Children who live in more deprived areas are more likely to be exposed to avoidable risks, have poorer outcomes by the time they start school. But actually, as the Honourable Member for Lady Wavertree pointed out, some of these things impact further down the line. A teacher at the weekend said to me, a child with poor linguistic skills, actually it impacts on their ability to learn to read because of phonics and so on. It's right, therefore, that support has a clear focus on reducing inequalities and targeting investment to meet higher needs. We remain absolutely committed to working with partners to identify how to support growth in the community workforce, including district nurses, general practice nursing, GPs, health visitors, school nursing. That team, as he so well laid out. We're putting in place significant actions to boost the workforce, ranging from training more nurses and midwives, offering new routes into professions, enhancing reward and pay packages to make nursing more attractive, improve retention and encourage those that have left nursing to return. I know that there is still that post-qualification, but I don't pretend there aren't challenges, as articulated by many, particularly around issues like CPD, which we are aware of and working on. We know that the number of health visitors employed by NHS organisations and reported through the electronic staff records shows a reduction. However, we also know it's not a complete picture of the health visitor workforce, who may be employed in social enterprises, private sector organisations and local government. And I would like to work with partners like the LGA and the Institute of Health Visiting to establish a much clearer picture, which is what they asked for in the Vision for the Future report. I think it was recommendation 12 and 13. And this will help move the debate forward. I'm pleased that Health Education England is also leading on the development of specialist community public health nursing standard, a standard that would cover several roles, including the health visitor, school nurse, occupational health nurse and family health nurse. And I'm keen for things to move swiftly. Currently, a specialist community and public health nurse apprenticeship, level 7's in development, as the Honourable Member said. This will offer an alternative route directly into health visiting profession on top of existing pathways which enable people to qualify as a health visitor. We must make the best use of these highly skilled and valued members of the profession and of the broader healthcare family, and ensure that they can optimise the good that they can do when they intervene in children's lives. Local authorities do remain well placed to commission health visiting and early years support, but in partnership, I would argue, with all those around. Of course I will.
So like many other members, I've been contacted by some terrific health visitors from Woking, and they do a wonderful job, but they do so against a very difficult financial backdrop. So as the Minister looks to resource this area in the future, can we make sure that there is fair funding across the country, including to our counties?
I thank the Honourable Member for his intervention. That links to the point that fragmentation remains a challenge throughout the system, running counter to the aims of that whole family support that the Honourable Member had stated. I believe strongly that there's scope to improve collaboration between councils and NHS bodies to improve delivery, particularly on those important issues around breastfeeding, immunisation and the like. Digital healthcare programme is an area where we're helping to overcome barriers, securing national backing so that information between key professionals is shared properly, and that is particularly important in strengthening the links between primary care and health visitors. But there's further areas where I think we can work better together to support those with higher needs. I intend to reflect on the points made during the debate this afternoon and also work further on the Vision for the Future report. The commitment to grow the public health grant as part of the local government settlement underlines the commitment to protecting and improving the health of the population, but local leaders remain well placed to make decisions for their communities, and we do have this disparity across the piece, and we need to understand the data better. Local decisions should be made on robust assessments of local needs, supported by workforce plans. Research suggests there are long and short-term educational, socio-emotional benefits of early childhood education and care, and the prioritised investment in early education, 15 hours free early education for disadvantaged 2-year-olds, is welcome. But I believe the benefits start earlier, your interaction with your health visitor at 28 weeks, or even before that in PHE lessons at school, where we talk about healthy relationships and equip our young people with advice on issues such as substance abuse and parenting. In the Prevention Green Paper, we announced our commitment to modernise the Healthy Child programme, reflected in the latest evidence on how health visitors are part of that wider integrated workforce, providing support. This work provides an important opportunity to work with partners, and I would like to take him up on his offer in his recent letter to bring with him academics and other interested parties, and I note the ones from across the chamber, to come and talk about how we can best move this forward. I want to ensure support is universal in reach, but capable of that personalised response, focusing support where the additional needs say we need to put them. I understand the continued focus on 5 mandated contracts, and which provide a vital opportunity for contacts with families. And national data does show that coverage has improved, but I do take on board the points. So I don't want to reduce those 5 moments, and I do think there is some interesting conversations around the other points of contact that have been mentioned. I have heard calls from health visiting professions that they're being pushed to tick the box but miss the point, and I've spoken to my own local health visitor lead on this issue. They are highly qualified professionals. They are really important in the leadership role, and it is a role I wish to reinvigorate. By working closely with commissioners, other professionals, particularly midwives, they are critical to a child's journey. If we're serious about supporting early intervention, then it means starting with relationships. Becoming a parent's important. It doesn't come with a manual. We all need help, and professionals provide an opportunity to give evidence-based advice and support. Our vision for prevention encompasses the whole life. We're now reviewing the Prevention Green Paper, including his response, which I know PIF submitted to the paper, and to ask ourselves the question and to work on what more can be done with local authorities and NHS bodies. In conclusion, to give every child the best possible start in life to fulfil their potential, we need to fundamentally change the way we operate. I want to ensure that systems are in place to help infants as they develop, move to school, grow into adulthood, overcome fragmented service provision and making the best of what exists, and then using evidence to make a resolute focus on those additional needs. I look forward to working with the honourable gentleman, and I am optimistic that we can make the change.
Order. I really apologise to right honourable members, but time has beaten us.